I have just a few slides regarding the biobanks we have in Sweden from children with cancer. And we have the two different biobanks, one for the hematological malignancies, which is here in Uppsala. And it's actually a Nordic one that started already in the late 80s, early 90s. And then we have another one, a later one, which has all the brain tumors and solid tumors in Stockholm. And the leukemia biobank here is a collection of approximately 7,500 primary leukemia samples. And some of them are at first time they get leukemia, some of them are follow-up samples, and some are because of relapse or suspected relapse. But there are approximately, I think today, closer to 6,000 unique donors of samples. There are cells from bone marrow and peripheral blood, and DNA and RNA extractions. There is some plasma, but the quality is not good because the samples have traveled from different centers and being on the way quite long time, and they are usually rest material from fecal separation. So we feel as the toxicity researchers that is really a problem, that we are at the moment lacking plasma. There is serum, which is good for some analysis of the biomarkers we have discussed today. And then we have started collecting CSF. And at the moment, I think it's more than 100 patients. We want to have CSF from all the patients in the current altogether leukemia protocol. What is good to know, the leukemia biobank has no data, or it has only data to identify the donor, but no sequencing data. And that is a big difference compared to the Barncancerfonden, the solid tumor biobank. But we collaborate with Genomics Medicine Sweden, and the sequencing of both the leukemic cells and the skin biopsies, the fibroblasts, the healthy cells, has been ongoing some years now, even for leukemias, and the data is collected in the Barncancerfonden, but we are still after in the number of patients, and also the process of how you get data is still pending. At the moment, it's the Swedish Leukemia Group that is responsible for the, like a scientific committee for the leukemia sequencing data. What we are doing now here is to try to get the follow-up sampling ongoing. Then we have the Swedish Childhood Tumor Biobank. And you can see here the number of registration patient falls. The blue ones are CNS, and the green ones are other tumors. And you can see that it's over 250 cases last year that was included, which means that in practice almost everybody is included. And there are fresh frozen solid tumor material, blood samples, some CSF, some imprints, some paraffin material, slides, and even viable tumor cells available. And for most cases, there are even samples from parents. And there is also data there. They have been before leukemias doing sequencing. Both DNA and RNA sequencing data is available for over 800 patients, and blood, which means the healthy cells, is over 700 cases, and this was in February, so it's accumulating all the time. And then even the methyllarynx array, over 500 cases. Well, and there is the same thing. We are collaborating both the Leukemia Biobank and Barncancerfonden to get really this follow-up sampling ongoing. And we hope to get it next year really working. Now it's some centers that are already starting, but we have ethical approval in both biobanks to do, because we think to be able to find out the mechanisms behind toxicities like the cognitive effects, we would like to do multi-omics analysis from the CSF and plasma serum, which are lacking today. But new requests of samples are welcome to both biobanks. In Barncancerfonden, it's a lot of data that people can use, and I think they really rather give the data. No one should sequence again. And there are very good instructions at the home pages. You find them easily, and it's very good to contact the biobank, or at least in leukemias, it's the registry that has the data on like how many certain cases are available, and then we can check in the biobank how many of them have samples. We worked with Päivi to get the information in the registry also, that if the patient has sample in the biobank or not. At least at that level. We don't know how many cells or what type of samples, but at least if they have said yes to biobanking of material. This was all I wanted to say. Thank you. Now it's Päivi.
Okay, thank you. Just a hopefully quick presentation about, or to those who are interested in research in all kinds of health registries in Sweden. The Swedish Childhood Cancer Quality Registry started in 1980s and already a little earlier with leukemias, but with the other tumors roughly about 1982. And all the university hospitals report, and the upper age limit is at the moment 18 years at diagnosis, which means that it's about 350 new cases per year that are registered, and the coverage compared with the obligatory national cancer registry is above 90%, and hopefully we get it soon, almost covering all the patients. But of course the quality registration needs the consent, the oral consent to be included in the database. And we have 8 modules, and at the moment about 13,000 patients included in diagnosis modules, so to say. Database is Inca, started with brain tumors in 2020, the new database, and now also the leukemia patients are reported in. And it's important to know and remember that the detailed registration of cytogenetics and minimal residual disease of leukemias continues to a database at Karolinska Institute, the former platform for the whole quality registry. So these are the 8 modules: leukemias, CNS tumors, solid tumors, lymphomas, and the so-called benign hematology. And then the kind of supportive or follow-up modules, SALUP, RATOX, and SAREP. And this is just to show that the numbers of different diagnoses, they have remained quite stable during the years. And from the Swedish homepage, the homepage with Swedish language only is in this web address, and from there all the researchers can find the instructions for planning a registry-based study, and also the application form that is used for applying data from the quality registry. And this is the most important information from the homepage. We really recommend that everyone who is planning a registry-based study is at first contacting the registry to discuss what is for example, what is the coverage of the variables and what do the variables really mean and so on. And I must admit that at the moment I don't have the statistics for each of the variables, but I learn more and more, and now the Inca statisticians are helping us to create something. But because we get more and more applications, and each time I'm a little bit surprised that where did this application come from, because I haven't heard beforehand about it, and then I know that there are similar projects initiated in other places and so on. And of course, everyone is free for doing research and so on, but there could be a possibility for more collaboration too. And then there needs to be the ethic approval. Then the application will be sent to the registry, which is myself at the moment, the chief of the registry, ansvarig registerhållare. And then thereafter, when the application is approved, then the data is ordered from the platform owner, and in our case it is the Regional Cancer Center West. And then it's one more thing that is important, that if you plan to contact the registered patients, it really needs to happen via inclusion of the treating centers, because it may happen that the previous children, for example, child patients, they might not still know that they are included in the registry, and still there are cases maybe from the past who really don't know that they have had a tumor, or that they have had a tumor, but they don't know that it is called cancer and so on. So it's very important that the contact kind of comes from the previous treating center, so that they recognize that there is at least the name of the hospital, and it doesn't mean that it physically happens there, but that the respective centers are informed, so that there is a letter of information signed by the center. And then the other homepage to the Regional Cancer Center is here, and from these homepages the researchers can find actual names of the variables called variabelbeskrivning for each of the modules, and that's the place where you need to pick up the exact names of the variables you are interested in, because you should have the list sent even to the ethical board and get approved in there to be really done properly. And the data quality, we know now that after changing the structure of the quality registry into the Inca platform, the data are now with high quality. The older data from the previous CCT databases needs further complementing, because some of the variables were not so optimal or modern, and on the other hand there was quite a lot of text data which couldn't be interpreted directly. And these graphs just show we have chosen 15 indicator variables where we have checked the coverage, and the right hand side shows how it looks like, for example, in the VCTP, the brain tumor module at the moment compared to the historical. But the good news is that we got financing from the national group for brain tumors, Barncancer, by which we can do the complementing of the data, at least to the start of the electronic journal systems, and so that's going on. And then a few words about the new infrastructure, which is called Barncancer Base. I told you about it last time when we had this conference, and the initiative came from this Lähteenmäki working group because we wanted to create a resource for making toxicity and late effect projects, and the steering group of the quality registry also happily approved this to be started, and now we have got the ethical approval. And the idea and the model behind this is fully similar as in adult cancer bases, and that are built beside the national quality registries of adult cancers. And this is just quickly a picture about it's based on the quality registry data, but it can be complemented with data from different national healthcare registries and registries from the Central Bureau of Statistics. And we need not to go to the details at this point, but this is the idea. And what is happening, what is important in the data management, so to say, is that it is processed data that the researchers can use within a secure platform. There's a secure environment at Karolinska Institute where the researchers, if they have all the permissions, they can either ask Barncancer-based statisticians to do the analysis, or do the analysis themselves within the environment and then get the results out, but not the data out. And it always goes so that the application needs to go to the quality registry at first, and if it is accepted, then the researcher can send it also to the Barncancer-based steering group. And I don't want to talk more about this at the moment because we just got the ethical approval, and now we are planning. We have, I think there is 10 research questions in the project plan, and which are approved, and now we are going to create work packages like neurocognition and cardiac late effects and epidemiology and so on, and at first we think that interested researchers who get approval from the system can join these work packages, but then of course later on we can broaden this up and totally new research questions can be later included. And I need to just mention that the ethics approval was conditional in that sense that they approved it for 10 years, and we can 4 times do all the updates for the data of the cohort. So this means that we can increase the number of patients in the cohort. Yes, but this was my
Okay, thank you, Päivi. And are there any questions for Päivi or me? I think if we think of this research on toxicity and late effects that we should promote, these infrastructures are really important, that enable researchers access, that it's not too difficult, but like in the register data, at the same time protect their integrity. And I think this is what the Barncancer base can really do, that it can protect the integrity of the survivors, that no one can identify anybody. And the data is not going to leave the registry. It's there. You can get the analysis done with support from there, but no one is getting access to any information they are not needing. They don't need to answer the study question like date of diagnosis or date of birth. Often you don't need it. It's enough to know age of diagnosis and then maybe the year of birth if you want to look how the things have developed by time. And the biobank is the same. I think we really have to work hard that we get them, the biobanks, including even the samples from the late survivors, like the follow-up clinics, in order to be able to see what really happens in the bodies. Like we know now, we all the time have more and more advanced methods to look at what happens in us and compare the survivors' like protein profile or combination of different profiles. How does it differ from the healthy individuals? But are there any comments? Everyone, there.
You start.
No, I would just like to add the comment for this Barncancer base, just like you said, Arja. It has a lot of advantages, and another advantage is that it's a fantastic shortcut for researchers, because at Barncancer base, researchers will work with registry data that will be data managed. So when other researchers down the road come and want to use the same data, it's already, I mean, the data management is already done. So this could both, there will be shortcuts, and there will be even, it will be even easier to collaborate within groups. So that's a great advantage too.
Maybe I could mention that getting the ethical approval was not easy, and that is also one advantage, that the researchers probably can use our ethical approval, that we can have it as amendment, or at least that they have included in base. And because now we needed to make, well, we got it not true. It went to överklagande nämnden. I don't know what it is in English. We wrote a comment, and they were not unanimous, but they still decided that they restrict our application to 10 years and 4 updates, and then we have to come with a new application. And there is a new law coming about the databases, and it is probably good time to do research now when we have this database. But please, Johan.
I would like to congratulate you for the quality control that you have made in the registry, because the output there, it's about who puts the data in, and we are using it then as hard facts, and then you have to have a quality control. But this costs a lot, and I think the centers themselves, so we put in our data, and then now you have a controller sits and look at that. At a time when this is not paid for by anyone, I guess you should also plan for taking a cost for this. That the researcher has to pay, because like you need a rat, you need these data, and maybe you should put it.
Yeah, this is there is a lot of for the Barncancer base. Definitely, we need to take a fee, because we need to hire the statistician and so on. But with regard to the quality register data in the cancer field, the register centers have at the moment a decision not to take paid, but many other quality registries do take payment, and it is under discussion, because it's of course we are dependent now fully on Barncancerfonden's financing for getting in the data and also running the database and even the coordinator and so on. So that's one issue. And then there is a lot of hurdle going on in the whole national system for quality registries. And now just I heard that for example the decisions about the financing will go to the Socialstyrelsen and so on, and there are many issues that will come up, but in any way that's good that you mentioned.
Yeah, I think Barncancerfonden is really supporting a lot these infrastructures, and the price is getting higher and higher. And well, what we have done now in Lähteenmäki, we have also applied money from other resources, for example, for Barncancerbase, and many have received also funding from other resources, which is of course welcomed by the Barncancerfonden also. And yeah, tomorrow we get one big decision also regarding Barncancerbase if we got money. But we have to remember our research is as good as our data or our samples. If they are poor quality, research is poor quality. So that is actually the base for high quality research is high quality data and high quality samples.
Definitely.
Yes, are you now satisfied? You have learned everything about neurocognition? Or was it the topic today? I think it was very nice to have a quite focused topic. We have had more like diffuse. It has been fertility, cardiovascular, and neurocognition. And now it felt very good to have one topic at a time. For one day, it's enough, at least for my brain. Are there any other comments, questions? No, everyone looks a bit ready to go home. Thank you so much.